25% of patients start treatment with a molecular profile. Is this of concern? Dr. Hart, what do you think?
Yes, it's a huge concern, and this is a problem throughout the country, both in my academic practice and my private practice at Florida Cancer Specialists. This is still a problem, especially it depends on the type of tumor we're talking about. In the lung cancer world, it's of particular importance because, as we know, if you treat the patients inappropriately with an immune checkpoint inhibitor and then they need to go on to targeted therapy, you can actually do the patient harm, and aside from wasting money and doing ineffective treatment. So it's a huge problem. And of course, in the lung cancer world, frequently there's small amounts of tissue that are there. So it is a huge problem. I'm sure that the other physicians would say the same thing. As a matter of fact, I was talking just today with the family of a patient in North Carolina who's in his 80s, and the diagnosis was made on a malignant pleural effusion. The patient is not really a candidate for anything else other than a targeted therapy or immunotherapy based on his overall condition performance status. He's not really a chemotherapy candidate. So, it's a tough decision. We don't yet have any the molecular data back, and it's going to be very hard to get it from tissue. So that's an ideal situation to try to use a liquid biopsy to speed things up. I was just talking to the family today about the patient who, and they of course want to know, when can we get started? When can we get started? Why are we still waiting? So this comes up all the time and is a very frequent problem, especially speaking in the lung cancer world.
Thank you for sharing. Dr. Reeves, do you have any insight?
Well, I'd echo all those comments and also say that, many of our clinical trials that we're looking at, those that are targeted in first line, require that the molecular profile be known for many of them. And so if patients start therapy before the profile is available, then they may find themselves ineligible for a clinical trial that actually would be a very good choice, or perhaps the best choice for that patient.
Well, thank you very much. Dr. Walker?
Yeah, I completely agree with Dr. Hart and Dr. Reeves. It's really an astoundingly low percentage because we're in the immune era of treating cancer, precision oncology, personalized cancer treatment, and we have the tools with next generation sequencing, both tissue and blood. You can get the molecular profile from a simple blood test. And it's so often forgotten or an afterthought that time has passed, the patient's getting anxious to start treatment, and then it's like, by golly, we did not get it. And setting up a programmatic approach can really overcome a lot at an institution, at a group. You set up the parameters of who needs the liquid biopsy for the molecular profiling. You get it as soon as you possibly can, even ideally at the time of the tissue diagnosis, and you will have it at the time that you're making a treatment decisions, and patients will get the best possible treatment. And if you don't have the molecular profiling, unfortunately, patients run the risk of getting a worst possible treatment.